All right. My name is Rebecca Webb. People call me Becky. I am a residency manager at a 777 program in the western suburbs of Chicago at Advent Health LaGrange. We are the single affiliated medical school with a DO school, and we are a small community hospital here in, like I said, the western suburbs of Chicago. So today I wanted to provide you guys with some information regarding the ACGME Family Medicine Program requirements that will be effective as of July the 1st. So bear with me here. I am working off of my phone instead of my computer. So I am going to try and do my best to see this small, tiny little screen here. All right. So objectives for today's learning will be to identify family medicine specific ACGME program requirements, explain what's changing for the academic year 2026, and locate requirements within the ACGME Family Medicine Program requirements online. Next slide. Thank you. So why family medicine has specialty specific requirements? So the reason being is training spans the full lifespan, so it's very different from any other specialty. There is a emphasis on longitudinal continuity. So we are one of the only specialties that concentrate over continuity over, the entire time of training. So that's how we differ also. And then we also are required to have education for residents over multiple settings. So inpatient, outpatient, nursing home, things like that, which no other specialty really does. Okay, next slide. Thank you. All right. So for those of you that are new or haven't had the joy of having to look up a family medicine program requirement on the ACGME site, they make it quite easy for you to be able to find things. You just have to know what you're searching for. So how to read the FM program requirements. So the program requirements are organized by oversight, personnel, education, program, and evaluation. So those are the topics. And then under each one of those topics are the requirements that you would need to know. So each requirement has a section and a number. And then there are citations in the program requirement document, which makes it a lot easier to help locate expectations quickly. So next slide. Thank you. Okay. So newly enforced for 2026 AY. So CBME will be fully enforced. So that means anything that is in the program requirements will need to be upheld. They're going to be watching for that this year. There will be a greater emphasis on outcomes, and there will also be higher documentation expectations for programs. Next slide. Okay. So educational structure must support the family medicine outcome. ACGME competencies are integrated and flexibility requires documentation. So this is the section in which I found that information. So under section 4, educational program, these are the citations. The program must be structured to ensure residents' develop competence in the outcomes expected of family medicine physicians. And then the programs must integrate all ACGME competencies into the curriculum. So I don't know, for the new coordinators that are on or administrators that are on, there's wording in the ACGME program requirements. When you see the word must, you know that that is something that you need to incorporate, and it's something that must be done. So make sure that you're making changes to your curriculum guidelines, things like that, to include those things. Because if the ACGME questions, if it comes for a site visit, all the things that are must are just what it says, musts. So you need to be able to show that that is something that you are doing. So this is where I got this information from. Next slide, please. All right, knowledge check. I thought this was a fun slide, so you guys would be excited to answer questions. Just put your answer in the chat. I'll give you guys a second. So which best reflects CBME expectations? Meeting our minimums, demonstrating outcomes, or number of rotations? Yep, I keep seeing answers. That's great. I'm going to give you guys a second to get your answers in. Looks like B, all, B, B, B. Okay. Outcomes. Awesome. Good. You guys are paying attention. I love that. All right, next slide. All right, correct answer is B. CBME focuses on demonstrated competence and outcomes. So that is what it says in the program requirements. So that is what we need to follow. Next slide. All right, so oversight and participating sites. So in section 1 under oversight in the ACGME requirements, it states oversight is required at all participating sites. Sites must be approved and listed in ads. And PLAs required for required rotations. So next slide. What this PLAs is one of the biggest citations that programs get. I don't know if you guys are aware of that. So there are requirements in the program document that the program is responsible for education quality at the sites. So I don't know if you guys knew that, even though you're having some other faculty member or some other attending physician sign off that they will have oversight of those residents while they're rotating there, the program at the end of the day is responsible for the education and the quality that they're getting at those sites. PLAs are required for each participating site. So if you are sending your residents out to do a rotation with an endo doc, you need to make sure that you have a PLA. If you're sending them out to ortho, you need to have a PLA. If you're working with an FQHC that is not part of your hospital system, you need a PLA. Anywhere your residents rotate, as long as it's not owned by the hospital, you will need a PLA. An ad must reflect current sites. And if I am not, if I'm not incorrect, I am pretty sure that current sites or sites that you go to for PLAs need to be, approved by your DIO. So DIOs need to sign off on all PLAs. So in section 1 under oversight, the program must ensure oversight of and responsibility for the quality of education at all participating sites that provide required educational experiences. There must be a program letter of agreement between the program and each participating site that provides a required assignment. So that's where I got this information, just in case you guys were wondering. Next slide. All right, another knowledge check. Which oversight item is most commonly cited? Clinic schedules, missing PLAs, or faculty CVs? Awesome. I know, my knowledge checks are easy, but you will remember that knowledge check. So go ahead, next slide. Megan, thank you. All right, missing or expired PLAs are a frequent preventable citation. That was found section 1 under oversight. So it is preventable because all you have to do is get a PLA, which could be very difficult depending on your legal department. All right, personnel requirements under the administrator role. So this is what section 2 states in our family medicine specific requirements. Support for PD eligibility and time. This is what we are supposed to be helping with, just so you guys know. Ensure sufficient core faculty and then maintain accurate ads data. So these are our main administrator role responsibilities as per the family medicine specific program requirements. And again, that was section 2 personnel. Go ahead, next slide. Okay, so this is program coordinator requirements and where to find it. So in section 2, under personnel, this is your citations. There must be a program coordinator, and the program coordinator must be provided with dedicated time and support adequate for administration of the program based upon its size and configuration. So it's super like vague. It doesn't give you specifics. If you look into the FAQs, there is a section in the FAQs where it breaks down by how many residents. Will say how much FTE the program coordinator is required. I just saw a question pop up about, is one program coordinator sufficient for a 666 program? Yes. Actually, I think it's less than one in that FAQs. But again, if your program director and DIO use the information regarding your program and what your job description is and what your responsibilities are within the program, they will fight for you to have full-time equivalent. And it basically is up to the administration at your hospital or whoever owns your residency program. Even though the ACGME put that out there, that is just a suggestion. So if it says like 0.6, they're saying at least 0.6. They're not saying only a 0.6. So it would depend on other responsibilities. And I believe it does say there in the FAQs that it would be all dependent upon what other responsibilities that person has, but at least the minimum of whatever it is on that, on the FAQ. I can maybe pull it up after we're done with the rest of the presentation so I can show it to you. All right, next slide. Sorry, give me 1 second. Ooh, sorry. All right. Continuity clinic. This has not changed. So foundational to FM education, longitudinal patient relationships, and progressive responsibility. That is what our program requirements state that we need to offer to our residents over their 3 years of residency. So this is not changing. Continuity clinics are going to still be required. Numbers will be required. Those the cases in ACGME, those will still be required moving forward. And we need to show that we're meeting those minimum percentages. I believe it's like 30, 40, 50% from first year through third year of continuity of not only seeing their own patients, but those patients seeing their assigned physician also. All right, next slide. All right, this is where I found these requirements. Residents are assigned to primary FM practice. Continuity is foundation of education and panel management over time. So section 4, educational program, with those citations, each resident must be assigned to a primary family medicine practice that serves as the foundation for that resident's education. And then residents must be primarily responsible for a panel of continuity patients, integrating each patient's care across all settings. So that's where I found this information. Next slide. All right, now let's check. Does inbox or charting time count towards continuity clinic? A is yes, B is no. Nice. Great job, guys. Next slide. Correct. Answer is B. Only direct patient care time counts towards continuity clinic. So when you're putting in your how many hours were they in continuity clinic at the end of the year in web ads, you need to make sure that you're not calculating any time that they would have been charting. If they had like 20 minutes free in clinic and they decided to chart, to chart during that time does not count towards continuity clinic. Next slide, please. All right, evaluation and clinical competency committee. So these are the 3 responsibilities of our CCC and evaluating residents. Documentation must support decisions. The CCC meets at least twice per year, and they have to utilize the milestones in their evaluation at some point. So if your CC is meeting twice a year, most likely you guys are just doing milestones on those residents. Our competency committee does meet 4 times a year for evaluation of the residents, and we do 2 semi-annuals and we do 2 milestones. So every quarter we are evaluating our residents so that we can get a little bit extra than just the milestones discussed. I am finding this in section 5 under evaluation. These are the things that any site visitor is going to uphold. So make sure your documentation supports any decisions that your CCC has. So if you guys decide to put somebody on a PIP, and your CCC minutes are not complete and it doesn't show that the CCC committee decided that they were going to put this patient or this resident on a performance improvement plan, then you could get cited for that. You have to make sure that you're documenting everything and all decisions that were made and then following through on that. And then, of course, putting your milestones into the ACGME website at the times in which it is required. Next slide. All right, so this is where you find this information. CCC reviews all evaluations and determines milestone progress. Section 5, evaluation under those citations. The Clinical Competency Committee must review all resident evaluations at least semi-annually. So that is the requirement. And you see that it says must. So, and then the Clinical Competency Committee must determine each resident's progress on achievement of the specialty specific milestones. So those are the 2 requirements. So you have to at least meet to evaluate residents at least twice per year. Next. All right, so these are the common family medicine administrator citation risks. So PLAs, which we already discussed, your accuracy on web ads. So not just the numbers that you're putting in, but also, making sure that your specialty docs that are working with your residents are listed, making sure that your faculty is correct, the FTEs that they're working are correct, making sure that the CVs are in for those faculty members that are required, which I believe is the PD and maybe APDs. So make sure that you are not only updating web ads only when web ads is open, but you can actually go into web ads and make all corrections throughout the year. So if something happens, a faculty member leaves in February, you can go in there and you can finish them out in February, and you can add new faculty at any time also. Same thing with residents, same thing with any information that's in web ads. And then the CCC documentation, that's a big citation risk. And then also any kind of continuity data. So if you're not getting the correct data in, if your data shows, that your residents are not seeing the correct percentages for a long period of time, I'm sure that will prompt a citation also. Next, please. Thank you. So key takeaways. FHEM has a unique specialty requirement outside of other specialties. So that's something for us admins to be aware of, because there's more things we need to keep track of. They don't just go in and document, cases like surgery does. So this is very different. Continuity numbers need to be kept track of. We need to be utilizing our electronic capabilities to be able to get numbers that make sense, make sure that we are reporting that and using that major changes section to explain anything that may look a little bit off. So in the academic year 2026, emphasis will be on outcomes and documentation. That is what I'm hearing is being passed down. So that is what you guys need to focus on. And then knowing where to find the requirements in the ACGME common program requirements, as well as specific family medicine requirements, is very important so that you can reduce any risk, because you'll know what those requirements are. Next. All right, this is the question and discussion section. I'm going to see if I can see the chats. I believe I can. Okay. So there were some questions that I saw. I'm going to go back to the top just so I can make sure I catch everybody. Yes, the slides will be available. I will put them on our YouTube channel, which is AFMA webinars. On YouTube, I will put the recording, as well as I can upload my slide deck to the listserv. Okay, next. Oh, Shantae couldn't hear me. All right, every single site, like ortho, needs to be listed in ads. So I'm assuming we were talking about PLAs at the time when this message came through. So you should have a PLA for every single site that your residents are going to for educational purposes. And then the person who is in charge of that rotation for evaluating your residents while they're there should be listed in your web ads. At least that's how I do it. It makes it very much transparent. That way you're kind of holding those people accountable. The only thing I will tell you is that also means you need to collect scholarly activity for those people. So if that is not something that you want to do and you want to leave ortho off, then I would have a conversation with your program director or DIO to see if you would be within the program requirements and not get cited for that. Next question was, is one program coordinator sufficient for a program for 666? And look how amazing Ashley is. She put that list in for you guys. So if you have a 666 program that's 18 residents, that is going to be a 90% FTE, according to the ACGME. Next, every single site. Oh, well, we already answered that one. Only if going outside your institution. Yep. Whoever wrote that, that's correct. Also, that's what it said in the requirements. All right. Does anybody already have a checklist created that has all requirements listed for 26, 27? I do not, but I will be putting one together unless somebody here wants to be helpful and send it. I sent one out for everybody last year. And the year before, I put it on the listserv. So I can be doing that again. Really not much has changed in the program requirements. They're just emphasizing, being a little bit more open with making sure that PLAs meet, curriculums meet the goals, making sure documentation is good. Those are the things that I've been seeing. Let's see. Again, the YouTube channel is AFMA webinars. And then somebody said, I'm curious as to other programs that are not standalone residency programs. Now that we're emphasizing longitudinal experiences, this could potentially impact other programs' experiences. For example, geriatric nursing home visits are also done with IM. I understand the importance, but it will be a slight burden on other programs. So going to nursing homes has always been a requirement across multiple sites. I think they're just looking into it more now. I know we've always gone to nursing homes. So who typed this? I want to know in what context you're saying it's going to be a hard time now. If somebody could unmute and talk to me.
Hi, this is Paula Ebert. Thank you for taking my question. So Yeah, so we're implementing our very first longitudinal nursing home visits, and we are on a 13 block year. And when myself and the internal medicine administrator, transitional year administrator, basically we're trying to make sure all the bodies are fitting and everybody's getting their requirements. It's very
Got it.
collaborative. And so we're on a block schedule. So when my residents are on geriatrics, they do nursing home visits. The same is true for internal medicine. They do the nursing home visits on Tuesdays and Thursdays. And now that we're incorporating only the second years this year, and then we'll move into the second and third years. What I'm, for the geriatricians, they don't want too many bodies. Plus, we have medical students. We're a contracted site for UW-Madison. So I'm a little early in this, but I've been around long enough that I can anticipate some challenges. And so
Sure.
um
So
I
your
don't know.
biggest concern is that they may end up being there at the same time,
Yes. And I
and
mean,
they
I'm
may
working
get in
with a
each
group.
other's way with experience, right?
Exactly. So I mean, I understand the importance for this, but I think that it could be challenging for somebody like myself who's in a community-based hospital with, I mean, we're a good sized city with a surrounding area, but we have other programs too. So
Okay.
I'm just, I don't know. I don't know really what I'm saying. It's kind of new, but I have
I understand.
concerns.
So is there anyone I mean, right now I'm at a community program. There are no other residents rotating at the nursing homes that we go to. We
Yeah.
have a geriatrician that's on staff here at our residency, one of our faculty members, one of our core,
Mm,
that is the medical director of our geri rotation. She has 3 different nursing homes that we admit to that she sees patients at.
mm.
So, I don't have the problem with other residents rotating there, but if there's anybody else that's on this call that does have nursing homes they rotate at, that has other residents rotating there, can you maybe connect with Peggy or tell us now, like, how are you guys managing that? Are they getting in each other's ways? And how would she stop that from happening? Other than just being on top of which day they're going, which is
And I have.
crazy.
I've already
It's
sent the
crazy
internal.
though.
I've sent the internal medicine administrator dates that I'd like to do it as I build my clinic schedule. But
Mhm.
um, do you know nursing home visits versus assisted living, are they different? I mean, obviously they're different levels of care. So do you know?
Um, I feel like assisted living is more of a home visit than it is a nursing home visit.
That
And
makes
can
sense.
somebody else chime in? Hey, is Annette on there? Is it not online?
That makes sense, Rebecca.
Yeah, I mean, in my mind, that's how I look at them.
I would see it as a home visit as well.
Okay. Um, so I would say that those are separate. Now, we have a requirement for our residents that they need to have 2 home visits before they can graduate. So we give them 3 years to get 2 home visits in, but we don't even send them to somebody's home in their first year. It's usually second or third year. Um, and we
Yeah,
do have
we
patients that live in assisted living, but they're calling
okay.
those home visits.
All right, thank you. Yeah, currently we're fulfilling the home visits with follow-up TEC home visits. So somebody had
Yeah.
like a cardiac event or something, and so
Uh-huh.
we have a team that they're going out with. But that begs the question, does a doctor have to be there?
I think a permanently licensed physician needs to be at the home visit in order to bill out for it. At least
Okay,
that's unless it's going to be a nurse that can bill out, right? Like an
but
APN, nurse practitioner, something like that. But
but
in order for it to be a home visit, I believe it needs to be billed out. And I think the only person that can do that is a licensed practitioner.
okay, thank you. I've learned something else. Thank you.
Rebecca, you are
Hopefully I'm
correct.
correct.
Yes,
Okay,
you are correct. It just happened to us at our program, so you're correct.
fantastic. All right. So next question was, first of all, Miss Annette made a crosswalk with the new 2026-27 requirements, and she said she can put it on the listserv tomorrow. So thank you so much, Annette. I don't know what we're gonna do when she retires, yo. Just saying. So related to the listserv, is there any way to get daily summaries of messages instead of each individual messages? I get a bit overwhelmed with all of them. I agree, Miss Sandy. What I do is I set a rule for my listserv emails that come in. They go directly into a folder. And then when I have some downtime, I can go to my folder and I can look through them without getting overwhelmed. So I hopefully that can give you something that might help you not get so overwhelmed. I mean, my institution sends me at least 30 emails every day, and those get in the way. I can't imagine if I had the listserv going into my inbox, I would probably die. So hopefully that helps. Our residents go to the nursing home every 8 weeks, 888 complement. This satisfies the longitudinal experience for us. This way, the nursing home has someone every week. I agree. We do the same. Thanks, Ashley. All right. Yes. Awesome. Emmeline does the same thing with her listserv messages. Perfect. All right. Anybody else have any other questions? You can feel free to put it in the chat or unmute and talk. We got done quicker than I was hoping, but more time for questions, right?
Hi, I'm Bryn. I'm sorry to belabor this. I just am always at odds with my program director about the listing of the participating of sites and ads.
Mhm.
With every single outpatient rotation that we go on, it's still like we have PLAs for sites that were approved by, the DIO and everything, but we only have our two major hospitals listed as our sites.
That's correct.
So I don't need to list GYN and ortho and all of the other outpatient.
Nope. Participating sites are places where you go for education. They're not necessarily like each specific outpatient clinic for each specialty. It's more like what, like, I don't know how to explain it in the way I'm thinking of it, but I'm going to try really hard to not bumble through this. I only have listed our hospital and the other like our sister hospital. I don't have like the clinics that they rotate at. But under my web ads, like doctor list, the faculty, I list my specialties there only if they're required in the family medicine specific requirements. So like if you have to have 100 hours of ER and 100 hours of, I don't know, or 2 months, 200 hours or 2 months of EM, then I would list those people on my faculty list as being, like site directors or what have you. But I wouldn't list the ER, and our ER is not owned by our hospital. It's like the doctors that are there from a different outside company, but I don't list that. I know I list our hospital and the other hospital. Like if we go to a specialty hospital for peds, I list them also. So we go to Lurie Children's for our peds ER, I list them. So anybody that not necessarily have a PLA with, but like are a sponsoring site. If that
And
makes sense.
just because there's a PLA, that does not make them a sponsoring site, and
That is
therefore not
correct.
every single. So even though it's a required rotation, like ortho, or GYN,
Right.
we don't have to have each one of those listed.
That is not my understanding, no.
Fantastic. Love that for me. Thanks.
You're welcome.
Thanks for following up with that, Bryn, because I was going to ask the same question. That's always been my understanding as well. Just the neighboring hospital systems that we work with for inpatient peds and those kinds of things are the ones that have to be listed as participating sites. So we have three.
So if it
we have
makes it
three.
easier, you can always think of it this way. If you have to transfer CAP to them, you need to list them.
Correct. That's correct. That's why.
Just if that makes it easier for you to think of it that way.
That's the easiest way to distinguish it for sure. Thank you.
Yeah, absolutely. All right, so next question. Whew. Lost my place. All right. I do have PLAs for my electives. I may have misunderstood, so I wanted to clarify. Is there ACGME requirement for residents to conduct home visits, or is that your specific requirement? So that is our specific requirement at my program. I don't recall seeing anything in the family medicine specialty requirements saying anything about home visits. What it does say is that there needs to be continuity of care over multiple sites. So, a lot of programs out there do not do home visits. They just go to the nursing home, they go to the inpatient side, and they see patients in the outpatient side. And that's fine, that's multiple. Nowhere does it say it's required to have a home visit, but we do home visits here at our office. So then we make sure that our residents have gotten that experience also. Hopefully that answers your question, Courtney. Yes, Shantae said her hospital requires them to have a PLA for every elective. It is exhausting. I agree with you, but we also, our hospital requires us to have a PLA for every single rotation. Except they say if it's owned by our hospital, we don't need a PLA, which kind of feels really weird to me. So I make sure we have one anyways.
We're the same way. They don't make us, as long as it's within the OSU system, we don't have to have a PLA. But mind you, I have 40, it's just a lot. I have 40 residents, and then they each have X amount of electives apiece, and
it's a lot.
It's a lot.
I mean,
yeah.
we have like a base list of electives that we have already set up. And I have ongoing PLAs with those electives, so it's not really like a block responsibility. Usually those PLAs are out there. I think they're good for like either 5 or 10 years. So as long as if your DIO changes, you get them re-signed and that kind of thing, you'll be fine. But like I have 2 sports med residents this year that are really, they're interested in going into sports med, I should say. So they want to do all these like outside rotations. They want to like, rotate in sports medicine fellowships in most of the Chicago programs. And I do have PLAs with some of those programs, but some of them I do not. So, just making sure that we're reaching out to those rotations, those hospitals, because it's not a big deal if it's a private office that's owned by your hospital. You're not really transferring any cap in any way. But like we're being Advent Health U Chicago, if we were to send one of our residents to Rush, there could be a cost thing there, right? We're giving them our resident for even if it's just a portion of a rotation that needs to be documented somewhere. I cannot tell you how many documents I've had to send out because we send our residents out to Lurie's and they're supposed to be there 70% of the time and here 30% of the time because they still do continuity clinic even when they're on their peds ER rotation. But Lurie's will claim 100% of our resident. And then I submit my Irish report, they submit theirs, and now there's something going on. Those things are supposed to match and they don't. So you have to go through, pull all of your like logs for duty hours. You have to show, your contracts that it says 70-30 split. And then you have to have them fill out paperwork saying that, they're going to go with the 70-30. They're sorry, that they claimed 100%. So before the Medicare can pay out programs for their FTEs, they need to make sure that all of those things match. So it's always good to get, a PLA so that it actually states that in there so that you have something backing you up. Let's see. All right, so I'm wondering how programs are keeping track of the patient panel, resident cited and patient cited. So we had a webinar not too long ago. I don't know, Anika, what system are you guys using for medical records? Is it Epic?
No, it's New Innovations.
I don't know how it works for New Innovations. I know pulling, we can pull from the slicer dicer on Epic, those reports, and they will tell us exactly what the percentages are. If you're only using New Innovations, I'm not quite sure. Is there anybody else on that's pulling that information from New Innovations that can help her?
What are you pulling from New Innovation? Sorry, I didn't hear the first part, it cut out.
Patient panel, resident cited, and patient cited continuity.
So are the residents self-entering all of that into New Innovations? Because that would be the only way you could pull the data.
Yeah, they're entering the information themselves.
So what EMR does your institution use? Not New Innovations, but do you use Epic or?
We use Sorian.
Oh, okay.
All scripts Sorian. Yeah.
All scripts.
And does it not have reporting that you can get that? I don't know. I would just not trust the self-reporting from the residents reporting all of their data.
Yeah, that's why I was wondering how some of the other programs were using, what software they were using, and how
Yeah, we use Epic.
they were
so
trying
we're
to get that data.
We can pull it directly from the EMR. I don't know if you could work with your
Oh,
IT
so you-
team and see. Well, yeah, we
So
just
what
pull it
EMR do you-
directly. We have Epic.
Epic, okay.
Yeah, so we
Okay.
just pull all of that data directly from the clinic, from the EMR. So it's not self-reporting, or else the residents would have like 5 encounters or people on their panel because they've never
Right.
it.
Yeah, okay. So does anyone else use any other EMR other than Epic, or have used like all scripts?
Annika, we had all scripts before Epic a few years ago, and those reports should be available to you or to your practice manager, however it works in your system.
Okay.
You
So
should
let
be
me
able to
check
get
into
them.
that.
'Cause
Okay.
I would definitely not rely on them and New Innovations for sure.
Or would I?
Okay. Thank you.
No problem. So Ashley says they're the same way, hospital and services. They don't have PLAs, but outside rotations or private practices have PLAs. So, somebody else said we do the same thing. We have a mini PLA for short-term electives. That's smart. Same for us, PLAs for all and approved at GMEC. Affiliated do not require GMAC approval. Yes. I need to leave, but thanks. Bye, Deborah. Sorry. You had to go. All right. Annette also had to run. Thanks for coming. Have a great week back. All right. It looks like everybody is just thankful for the webinar, which I appreciate. Hopefully I gave you enough information. If you have any questions, my name and information is on the last slide of the presentation. So you should be able to get in touch with me in case you need to ask some questions or you need some direction on how to find things in the ACGME. You're welcome, guys. We'll talk to you soon. Have a good one.